first. So share screen. This one is the one I need to share. Cool. Um, so topics. Okay, so there should be case 75 for those of you that can log on to this, let's say, forum. And then I'm going to share this, which is the link to the images, and share them through the chat. Okay. Well, so you should all be able to download the images and open them in your computer and take a look. Let me give you some background. They're all real, but this is real, because it's not taken from my library of cases, but rather like it's a case that showed up in the clinic. So, and George, maybe you can give more background. I forgot to update this. When I got this, I just put whatever I remember from walking by the case, which is that it's an older Pomeranian that represented dyspneic, but I think was also cyanotic. But just correct me if I'm wrong.
Yeah, it was cyanotic. I think initially on presentation, it was put into oxygen and then didn't really respond until it got its sedation.
Okay, so let me open the images, and we do what we always do, is we go through findings. Okay, so things are not written on stone. There is no proven way to do things. So what I'm thinking now is, if you're looking at radiographs, I think in your situation, everyone that is in this forum, other than me, probably you are involved with the case, so you know what's going on. So then there's no option for you to take a look at the images without having that information. If you're gonna be helping someone, and someone, just because you like imaging, someone's gonna come to you and say, do you mind taking a look at the radiographs? One of my suggestions would be to take advantage from that absence of knowledge. Makes sense? So probably I would not ask first for the clinical signs. I would take a look at the images first, knowing that I'm doing something, knowing that I'm going to be limited, and knowing that if I add the clinical signs and the history and everything to that, I may completely change my mind. So I'm not going to stick with what I said, but I prefer to have that impression first and take note. And then if you're preparing a salad, you put the different ingredients at a time. The problem is that if you know the history, then that information is going to bias how you look, and there's no way to come back. So that opportunity you've lost. Because once you have that information, you cannot erase it from your brain. So the way that I usually act is like, I'm just saying this because I show you the history first. I don't know what, probably next case we should change that and go images first. I'm not saying that the history is not important. I'm saying the opposite. I'm saying take the opportunity to take a look at the images without being biased. Take note of that, and then include into that mix, the history, and see how if you're gonna change your mind, and in which way, and how that information is gonna change what you think. Anyway, this is just thinking aloud, and it's kind of sharing what I do. That doesn't mean that is the way to do it, or is correct. What I realize is, after doing this for years, is once you have that information, you can get rid of the information. Makes sense? So then you are, if you want, at a disadvantage, because that information is biasing you a lot. Anyway, so yes, I'm all ears, and I have my little paper here, and I'm going to be taking notes about the findings. We have someone that is in a very bird happy area. I can hear plenty of birds. which is very cool. I'm not criticizing. I enjoy that. Okay, findings: normal, abnormal.
Very abnormal.
Okay, yes.
Now there's an area of
I think you went mute for like we could
there's
hear
an
you.
area of calcification.
Okay, yeah.
There.
Yeah.
You can see it here as well, almost, yeah, there.
Mm-hmm.
Probably, well, the trachea is elevated. There's also radiodense something there, and possibly it there above the heart. I'm wondering if it's tracheal lymph nodes.
Okay.
Is there a really small pneumo? I feel like there's like a tiny black line along the diaphragm. Whether it's just artifact or like real.
I see what you mean, and I think you can see that better in the right lateral project. Is that correct? In this one.
So the right lateral and the VD. Or DV.
Where in the DB or DB?
Is it? What was that? Sorry.
Where in the DB? Because I think I can see this border there, but I'm not sure I can see.
Just along here.
Okay. Okay.
Like it's it's absolutely tiny.
Okay. Good. Well, that is an interesting point, and sometimes, many times, the relevance of findings, and this is what sometimes annoys people, are not based on how big they are. Makes sense? So pneumothorax is one, but I don't know, pleural effusion, like a small nodule, like they are very small findings, but they're if they are real, and if we can prove that they're real, we are not dealing with an artifact. Even though they are 1 millimeter, their impact in the case is huge. So then, yeah, that's particularly something that I like, is that the more confidence you get, and the more confidence, the more small findings, but relevant findings you can identify, and then that usually changes the game. So that's fun for some people and very annoying for some other people, because it's like very small. You say, well, I'm never going to see that, and then that may have a very strong impact. So one of them is in a dyspneic dog. So the finding of if we are dealing with a small mediastinum, probably that small amount, I'm not saying that it's there, but a small pneumothorax, sorry, is not, the impact of that information is not going to be so much in a problem of mechanical, a mechanical issue. It's going to be like, well, now we need to think about possible causes of that pneumothorax. So now the list is going to change. So it's a small finding with a possible very large impact. Okay, we leave it there. I probably don't think there is pneumothorax, but we'll get back to that. So, okay, any more findings?
There is on the VD, if you look over the heart, there is a density. So Jeff pointed out the one on the sort of cranial left aspect, but I think that extends further. And I'm going to try and annotate this, and I can't. I'm not sure I'm going to be able to do it, but I'll see if I can. So I need to draw.
Very good.
Yeah, whoever did that, that's the one. But I think it's bigger than that. So I'm going to go, I can't draw.
Well, you could, like a minute ago.
Okay. Well, I don't know what I did. So I've got
Well,
draw, got a line. Try that.
No,
Hang on. There we go.
I suppose.
There we
Okay.
go. I think there's there. And I think I can also see it here on the left lateral. This looks like a cavitated something.
Okay. Okay. So, so you are kind of expanding on this idea that there is something abnormal in. So, correct me if I'm wrong. I think we are all agreeing that it's likely in the mediastinum, or not. That let's even go further away and say there is something abnormal somewhere around the heart. Is that correct? Because one is okay. I don't know how not to put an opinion and define. I think we are not certain what it is, so then it's hard to define it. So it's okay. So I take note, and then we come back and we try to undo this slowly. Okay. So anything else?
I may be suffering acute imaginitis, but I think there's I think there could be bony changes in the spine there. And there. There's also I'm getting the impression that there may be some compression of the lung here, sort of there, and you can imagine that it's there as well.
Okay. Okay. So am I right? Like for a second here. Issue. Okay.
I was just going to add that bulge that Jeff pointed out on the heart is sort of in the region of the main pulmonary artery, and then that would fit with in the lateral where the heart looks really tall, and like so this and sort of this bit looks enlarged here.
Okay. Okay. So tall. So now the addition that thing that we are looking at least part of it is in the area where we expect to see the pulmonary artery. Yes.
Yeah.
And then I think, Helen, you are putting that like an equal, or that also justifies the heart being tall. Is that correct?
Yes.
Okay. Good. Good. And then we explore all of this. Okay. Anything else?
I don't think, I'm not sure whether this is a true radiographic finding, but I feel like the lungs aren't as bad as you'd expect for the level of like dyspnea that was described. Like,
okay.
Like the heart looks abnormal, but the lungs don't look supremely abnormal. So why is the dog so dyspneic?
Okay. Okay. I guess the only thing that came to mind when you were talking about this is that it all depends on your expectation. Makes sense? So if you're gonna, like, it doesn't call my attention like a super dyspneic dog and a super normal radiograph. So for me, it's not super abnormal or super, it's not really shocking me. That's a very common situation. So it's not unexpected, but let me rephrase that, or how I would say it is, if we want to blame the lung only, and this is not also true, if you want to blame the lung, then probably it doesn't look that abnormal to justify the dyspnea. So if we want to make that assumption that the lung is to blame, then probably the lung doesn't look that abnormal. Yeah. Having said that, like in cats, you have like a tiny bronchial pattern, and that can be a functional thing, and it can be super dyspneic, and radiographically there are only minor changes.
Yeah.
But I take your point that at least first impression, the lung doesn't look like white. So if you're going to think about the options of edema, severe edema, contusion, like there's nothing very clear along those lines. I would probably rephrase it like that. And I would agree with that. Okay.
I guess just most commonly, like if they're dyspneic, you either got significant edema or you've got pleural effusion or you've got something going on. Do you know what I mean? But cats can have the mildest signs and be dreadful.
I completely agree with that. And then I remember, you know, I was lecturing, and then I remember like sitting down before the lecture, and there is so much. I don't remember saying, you know, what's my goal? I remember when I was teaching thorax, it's like, what's my goal? And I remember I would spend like one whole hour in and trying to go back and forth about the idea of lesion localization. So not even trying to figure out what is going on, but where. This big group. So you have a dyspneic, and this is, I think, what you are saying. So if you have a dyspneic animal, you take a radiograph. Can you make the big call? The big call is it the lung that is severely affected? Is it the pleural space that is severely affected? Is there a huge mass in the mediastinum? Makes sense? So can you give me the first approach, you know, the lesion localization? Then we can discuss, you know, based on details, you know, what's the most likely differential. And then having that very basic approach can also help you deal with a case. Like if there's a severe pneumothorax, you know, well, it's in the pleural space, I better put a needle in there, remove it. I'm gonna be helping the animal with that. If it's, or maybe let's do the opposite. If it's severe pleural effusion and I have the ability to identify that to the pleural space compared to a severe change in the lung, then one needs a needle, the other one doesn't need a needle. Makes sense? So that big thinking, that in groups, in lesion localization, I love it. It's perfect, yeah. And sometimes, you know, you need to go back to those big groups. So yeah, I agree. I was probably trying to warn that works most of the time, but in some cases, or that the severity, what I was trying to say is that the severity of the clinical signs sometimes don't match the severity of the radiographic signs. I just want to make that point. Anyway, what else? So now we need to kind of untangle everything. I probably would add that there are kind of hemoclips here, which they're in the periphery of the radiograph. Oh, I didn't show you there, but they're here. And I don't know what they are, but at least they're telling me that there was an abdominal surgery of some kind. Okay.
Another thing, Mariano, as well. When comparing the left and right laterals, particularly on the left, the tracheal lumen looks a little bit decreased, just caudal to the shoulder joint.
Okay.
I'm not sure if there's soft tissue opacity dorsally. So I'm assuming it's just some evidence of collapse there from the membrane.
Cool. So then you are, I suppose, like in a dyspneic animal, then checking the airway as far as you can, as far as you're taking the images, blood important. So I agree, and very good comment. So the way that we read this, and I think it works 90% of the time, is that there's usually this anatomical thing in the trachea dorsally, which is a membrane, and you know, we allow that membrane to move a bit. So as long as we can see the other border, so there seems to be another line there. So that, probably the way to describe this is to, let me draw, maybe this one. So if you, unfortunately, we don't have a cross section of the trachea, but there are kind of three things that can happen. One is something like this, which is going to be kind of the normal trachea. So this is a cross section. If you take the X-rays from the side, like in this case, the lateral projection, you're going to have three lines. one line is given by this border, another line is going to be given by this border, and another line is going to be given by this border. So you get two lines dorsally, one line ventrally. So I think this is what we see here. And so basically, anytime I see this, before I call it like a real collapse or narrowing, then I try to identify if there's another border up there. And if there is another border, then I say, well, it's just a membrane, I'm not too concerned. The other situation, which is a lot more concerning, is if there is going to be something like this. That's a complete collapse of the trachea. So in that case, and then maybe a membrane there. But then in this case, so what we are missing is that one, which is the tall one, the cartilage. So here the cartilage is failing. So basically here there are not three lines, or there may be three lines, but then the actual diameter is reduced. So that's the classic tracheal collapse. So I'm trying to explain, how I would react to that comment, and I would probably say that I think the diameter of the trachea is this is the larynx, and if you continue that into the trachea, it seems to be similar, and here is similar. So I think this is the membrane, probably clinically irrelevant. There is another situation which is relatively uncommon, but is there, and probably a good differential would be like a bleeding disorder, and then bleeding in the trachea, like rodenticide poisoning, and then there's going to be kind of edema of the wall, like a lot of edema, or if there's severe tracheitis, and then there's a lot of content in the trachea. So then you have like thickening of the wall, and then that is going to result in a very different appearance. So then you're going to have one line here, one line there. That's given by the wall of the trachea and the surrounding tissues, or the mineralization, like in this case of the rings. And then you have a thickened wall, and then you have like a line there, and then a line there. So, and again, technically, you can see that line because this is soft tissue against gas in the trachea. Okay, so this is just thinking aloud about your comment with the trachea. So I agree with you that we need to take a close look in a dyspneic dog as much as we can. In this case, I see that looks like a narrowing. I don't think it's a real narrowing. I think it's just the membrane. Okay. Hopefully you agree with me. Hope we're gonna delete. Okay. Anything else? Okay, so I don't know how we want to go about this. I can see two options, as we always do. So one is that people like object to some other people's comments and say, I disagree with that. I don't think it's there, or I think this is the case, or I think probably this is not going to work in this case. Or the other option is to start hypothesizing. What is abnormality? What is going on? Can we put forward like an idea that can bring all of the findings together? And by doing that, we would say, well, that thing that we saw next to the heart, in this scenario, that represents this, and this represents this, and this represents this. Makes sense? So that's one option. Another option is that we don't go anywhere, and then I guide you more. But I would prefer you putting hypotheses. Like there were 2 or 3 already there. One was the pulmonary outflow tract. If we're gonna pull from that idea, then we need to explain the rest of the findings based on that idea. The other one that was put forward was like, are those lymph nodes? And if that is the case, then can we pull from that idea and see if that fits or it doesn't fit, or if we can put all of the findings under that disease process.
Mariano, just off the subject a bit, on the right view, I don't know, I've got to get rid of that. I think the liver it's certainly beyond the costal arch, and it's the border just here is the border here is just a little bit rounded.
Okay, yeah, I how are you going to use that information? So, yeah, are you going to conclude that there is hepatomegaly? Because I can see the liver extending caudally to the rib cage if you take this as the cartilages. I see that. Maybe there's a bit of rounding of the liver. Maybe I agree with that. I would have an issue concluding that there is at least severe hepatomegaly because, you know, if you go by the gastric axis, the gastric is not that much displaced. And we know that in older dogs, kind of the liver can kind of flip a little bit or rotate and then move caudally to a rib cage. So out of all the features of hepatomegaly, which are displacement of the stomach, I think that's the most important. Then the rounding of the contours, that's another one. And then the extending caudally to the rib cage. If it's there, it's mild. Makes sense? It's not as severe. It's a question of a rounding. I probably in an older dog don't pay too much attention to this much caudal extension from the rib cage. You know, maybe other causes, and more than anything, the liver, the stomach being kind of the gastric axis being in the right place. So then, yes, maybe they are not super strong findings. And one thing that I would add is that there is no fluid. Makes sense because now you are describing that border, and that means that there's good detail. And I think that's probably that's probably even the most important finding here.
I was interested in the sternal contact that you have. This film is not particularly, it's not expiratory like the right lateral looks to be expiratory. There's increased sternal contact, I think, here on the left lateral.
Mm-hmm.
I don't know if that means it's the left ventricle because it looks very, on the DV, it looks very rounded here. I think that means it's the left ventricle, but I don't know how that fits in with the pulmonary outflow tract being enlarged.
Okay.
I feel like this area here, which we have said there is some increased opacity there, but you can see the bronchi, makes me think it's alveolar. But then the fact that you have reduced opacity also overlying the heart, I can't explain. So I guess I'm interested in things that can cause enlargement here on the right outflow area, because I think that's, even though it's rotated, I think that's a really strong finding. So I'm trying to think of things that can cause enlargement there in an old dog. Yeah.
Excellent. So your comments are excellent. I wonder if there's anyone taking part of what you said and moving forward. Because out of everything you said, I think in terms of the findings, I agree with everything, almost everything. I disagree with one of your interpretations.
Okay.
One of the things included. And then if we put that correct, then we kind of untangle the problem. So is there anyone, so I can summarize the findings. You said there is increased sternal contact. You are saying that there is, the shape of the heart is abnormal because there is kind of a reverse D. So this is the reverse D. That there is this that you probably take Helen's comment saying, well, that's probably the pulmonary outflow tract. So that kind of fits. Then you have an issue with this in terms of the opacity. We can leave that aside for a minute. But then where you get in trouble is, well, if this is the left ventricle, then I have a hard time reconciling an enlargement of the left ventricle with an enlargement of the pulmonary outflow tract. And I would share that problem. I would not know how to put those together. Is there any way out?
Maybe it's the right ventricle. I'm wondering if this also, the pulmonary vein is much larger than the pulmonary artery as well. And I'm wondering if a dog has heartworm disease. I don't know if that's differential that's going to cause this.
Okay, so now Now you have a hypothesis. Try to sell it to me. So try to tell me which from all of the findings.
Well, I think that
Putting that bad makes sense. So now we are finding good fits. Makes sense. So we are this disease. How well does that disease fit into what we see? And then maybe someone else comes with another hypothesis, and then we see how well it fits.
yeah.
And then how far we can go. Then we may go to a point where, boom, we can't go further than having these two options. But we need to play this game. Now we know all the little pieces. What's the best hypothesis? How can we put all of this together? So your comment, a good step forward is that is not the left ventricle, it's the right. So if it's the right ventricle, then we can put 2 or 3 of the findings together. So can you do that for me? Can you sell me the hypothesis of heartworm?
Because you would get, I've never seen a clinical case, but I believe you would get enlargement of the right ventricle, and I think you would get enlargement of the pulmonary outflow area. I don't know why you would get enlargement of the veins. Maybe just backflow. Yeah, maybe you do get enlargement of the veins. I would think you would get right-sided heart failure and some loss of serosal detail in the abdomen, which we don't have. You could get some enlargement of the lymph nodes in the perihilar area. I don't actually know what that looks like, but maybe that would explain the increased opacity that we're seeing there, and sort of a little bit of a very regular, not a diffuse increased opacity there. Maybe that would explain that. Random calcifications in the lungs. I don't know if that fits in with canine heartworm disease as well. I'm not sure.
Okay, excellent. So,
one of the classics of heartworm disease, as I understand it, is truncated and tortuous pulmonary arteries, and I'm not seeing those.
Okay, so that's half of the way out. So out of the other comments, so I agree with the enlargement of the right ventricle, enlargement of the pulmonary outflow tract. I love the comment and the assessment of the size of the liver and the fluid, because that is not telling us that there is no right-sided heart disease. It's telling us that there is no failure, but there still can be right-sided heart disease. And now, then we went into the problem of the expectation of having the arteries being abnormal and seeing the veins being abnormal. So I think if these, instead of being the pulmonary veins, are the pulmonary arteries, and probably we get another one here, boom, going like this, tortuous. Then we have a better fitting, makes sense? So now everything seems to be falling in place. Right-sided enlargement of the pulmonary outflow tract, enlargement of the pulmonary arteries. And I will probably add now that this big guy here, that's a pulmonary artery. And this is another pulmonary artery that extends all the way here. And this one is, there is some degree of obliquity, and that is boring us. But let me see if I window. So that, I think, is a tortuous pulmonary artery. And I don't know if you see here, but this is, so, if you have a way to tell your brain, take a photo now, do that, because this is how the very enlarged and tortuous pulmonary arteries look like, superimposed over the trachea. See that? I don't know if you see that here. There is kind of an undulating contour here, like something going wavy, boom, 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 boom. So that's a tortuous pulmonary artery. So things are falling in place. I think this is another tortuous pulmonary artery. I'm certain this is a large pulmonary artery. This is also pulmonary artery, and this is as well. I like your comments about the mineralization and putting that together with a granuloma. And then I don't know how many, and I don't know how many of the heartworm goes with mineralization, but they do go with abnormal lung and granulomas. So then there's another thing that you put into that bag, into that You're collecting evidence for your hypothesis to defend your hypothesis. So when I looked at this case, I walked by and I said, heartworm. And for me, there are many things fitting there. But then I got another, but then I said, well, could be other differentials. Can we think about differentials to have an enlargement of the pulmonary ventricle, enlargement of the pulmonary outflow tract, enlargement and tortuosity of the pulmonary arteries?
Pulmonary hypertension.
Yes.
Yeah.
And then can we think about options? Because actually, yeah, the way that I should have framed that is that, what we are seeing is like let's call them a constellation of evidence of pulmonary hypertension. It seems that the problem is at the level of the lung that is resulting in a right-sided hypertrophy. Make sense? So
Yeah.
enlargement of the pulmonary, enlargement of the ventricle and the pulmonary outflow tract. So think aloud about the possible causes of that. So one is heartworm, so that's a disease within the arteries. And here the list is a bit annoying, and I probably go to the book to open my mind.
Well, a leaky or defective right atrioventricular valve, perhaps.
Which one? So the atrioventricular, the tricuspid or the mitral?
No, the tricuspid, the right-sided valve.
Okay. But so that, I think is a good idea, and in this case may end up having that. But I don't think that can explain the changes in the pulmonary arteries.
It wouldn't, sorry, I'm getting confused here.
So anything causing decreased compliance, or anything that reduces the lung capacity to expand, so any other kind of blockages. I haven't obviously looked in the book. I'm just trying to think of generalizations here, but.
Beautiful. And I think that's the way to go in these cases, is to go big groups and say, and the way that I always open the book, and then the way that I go is actually any chronic. So if there is pulmonary thromboembolism, again, another possibility within the if it's chronic, I mean, those hemoclips there, are those in the adrenals? So, is this Cushing on?
Okay.
Cushing could be a cause for, I'm just thinking aloud again.
Yeah.
Pulmonary thromboembolism, that's one option. Any chronic lung disease, they can result in pulmonary hypertension. And the lung doesn't look normal, doesn't look hugely abnormal. It doesn't look like an acute edema, but there is a interstitial pattern. So can it be an interstitial lung disease resulting in pulmonary hypertension? I think so. That's certainly an option that I would consider. There are cases that I've been looking into the book, and I don't think we know exactly what happens. It's kind of an arterial disease. So basically, the arteries get like stiff, and there's pulmonary hypertension without any other primary disease, and that happens. But I've seen not too many. Probably we should ask Rita about that. And then I don't know how to make you think about what this is. And actually, I didn't think about it until someone told me. So maybe I tell you, because we are almost like 40 minutes. So this dog, I didn't know when I looked at the images. But then when I tried to find the clinician and say, this looks severe pulmonary hypertension. There was this, yes, this dog has a PDA.
Wow.
Okay, so how are we gonna, if we add that ingredient to the salad, how can we explain this? Because we had a PDA last time. That's why I put the PDA in last week's rounds. And can someone give us a brief summary of what we've seen last time? Because that's the classic. Do you remember? So the pulmonary arteries and veins were hugely enlarged. There was enlargement of the left atrium. And basically we said that there is a left to right shunt, and therefore the pulmonary arteries and veins, they look very distended. And the problem was basically on the left side of the heart. Makes sense? The left atrium. Blood is going out from the left ventricle. There's a volume overload. So the blood going from the left ventricle goes into the aorta. Part of that goes to the body. Part of that comes back to the lung and back to the left. So then there is a volume overload on the left that looks radiographically as enlargement of the pulmonary of the left atrium. Remember, left auricle, and then we had that bulge at the level of the aorta, that was the ductus, a young animal with a murmur. So that's the classic. Now we have a completely different picture in this case, but we know that there is a PDA. So I want you to take that and move on. How can we explain this? How can we explain that it looks so different? And actually it's presenting differently, and probably no one really mentioned this. Like, it seems that the murmur is not that clear now. So how can we reconcile all of that information?
I think I know where you're going, but I don't know. I can't say why, because you've got the blood flowing the other way. You're going to go from right to left now. This is what happens when you get pulmonary hypertension becomes so high, it goes the other way.
Mm-hmm.
But I can't quite put that in.
Why is that happening? What's the trigger of? So in the left to right that we had last time, then basically the lung could take all of that increased volume without an increase in the pressure, or without an increase in the pressure such as to compete with the left. Make sense? Yeah. So then there was still blood coming to the right. So what is that change from that patient to this patient? Why is that not happening anymore if it happened before in this one?
It's because over time you get the pulmonary arteries, to try and cope with the too much blood going through them, they constrict and then eventually get fibrosis and things like that. So the pressure in the right side is higher than in the left side, so the blood goes the other way.
Cool.
You get right to left shunting.
Okay, so then in the lung, the pulmonary arteries get upset. They start remodeling to deal with that increase. Some dogs do it, some dogs don't do it. I have a little bit of a quote to review this. I'll show you in a minute. But basically, the thing that changes the game here is the reaction of how the pulmonary arteries react to this. If they are gonna react by remodeling and then having pulmonary hypertension, then there is gonna be less blood shunting, or shunting the other way. And then that explains the abnormal appearance of the pulmonary arteries, that the pulmonary veins are not that abnormal because there's now it's compensating the blood, the volume overload. And then the increased pressure within the pulmonary artery is gonna be also triggering the changes in the appearance of the pulmonary outflow tract first, enlargement, and of the right now. Makes sense? Because now before the right wasn't dealing with an increased pressure because the lung was taking everything. Now the lung is not taking everything, so then there's going to be pulmonary hypertension, and that's the enlargement of the right ventricle is a consequence of the pulmonary hypertension that was triggered by the PDA.
Okay. Hang on, I'll just unmute it.
So this fits, and I remember after my first excitement about heartworm, then I said, well, actually, I take it back. This is a pulmonary hypertension case. Then we need to explore why. And then when someone said, oh, PDA, I said, okay, that's it. Then now there's no no more to investigate. This is a chronic PDA with pulmonary hypertension. I don't know if these guys, if they get like reverse PDA, sometimes it can kind of compensate and be kind of there. If it reverses, then it has this weird differential cyanosis that because of the anatomy of the reverse PDA, if you run this or if you exercise this dog, they're gonna have cyanosis of the back of the body and not the front. That's the weird thing because of the anatomy of the shunt, where it's sitting, but probably we are not going to go into there. Okay, but it's a beautiful case, and I hope you enjoy me bringing the PDA first and reviewing all of that last time, and then I think that kind of set the grounds to now discuss more like a complicated PDA. Okay, and then
suddenly deteriorate? Did it just suddenly reverse this shunt, or this shunt looks like it's been reversed for a long time? So
I think it has been for a long time, and I'm not sure what triggered these acute clinical signs. I don't know.
Okay. Could be unrelated.
I think the thought was the reason why this dog decompensated was it also had a really severe polycythemia secondary to the right to left shunt. So its PCV I think was like 80 something, and that's why it was it had like hyperviscosity syndrome causing the dyspnea.
Okay.
So what was the surgery that it had?
I don't know.
It was
I don't
totally
know.
It had its kidney removed. It had a renal sarcoma in the past. It's the world's most unluckiest dog.
Cool, it makes sense. I thought it was adrenal, but it was just in the area. Yeah. Cool. And then I copy this from the book. So usually in most of the dogs, then the low resistance pulmonary vasculature can deal with all the increase in the blood flow. So most of the dogs, I think, are going to end up failing in the left. And it's not very clear why some dogs develop hypertension. Apparently, those that develop hypertension, there is a relationship in between dogs developing hypertension and the size of the defect, meaning the larger the defect, the more likely they are going to develop hypertension. It seems to be kind of the larger the defect, the more shunting then kind of will go over the edge. And then there are two hypotheses. One is that actually, because this is sometimes found, not in this case, which is an older dog. So I think this is the classic where it was first a left to right and then a right to left, kind of reversed. But apparently in some dogs, the right to left shows up very early, apparently without enough time to reverse. So the hypothesis there is that the fetal high pulmonary resistance never really went down. And then that's the cause why this dog, they show up first as a right to left. And then in other dogs, and this is probably more related to this case or to the defect size, kind of is how the pulmonary arteries react to this increased pulmonary volume. And some dogs react by, result with producing pulmonary hypertension or remodeling of the arteries. And then basically what happens is intimal thickening and medial hypertrophy. So this is, every time I have a case like this, I come back to this because I remember that there are kind of two groups. Some dogs show up with a right to left early on and some dogs very late. And it seems to be these two. What it makes more sense for me is the very late, because in my mind, I can make the story of, left to right first, damage to the pulmonary arteries, and then reverse. There is a group of dogs that show up with a right to left early, and apparently it's due to this never, accommodating to lower pulmonary arteries when they're born. Okay, enough for today.
Thanks, Mariano. That was really cool.
Thank you.
That was great.
Unless you have questions, I don't know. Maybe you disagree with everything. I'll try to find later on like a case of a hard one. Obviously, I'm not gonna tell you, and I'm gonna mix it with other things, so then you're not expecting it. Yeah, I enjoy going to kind of topics, because like this one compared to last time, extremely different radiographs, same disease. So thinking about it again is very useful. I may visit again pulmonary hypertension.
I've got one quick question on the DV. you know, the caudal pulmonary vessels, you were saying that the artery is enlarged. I thought that was the vein, the one that's ventral. I mean, not ventral, central.
That's
Yeah,
what I was going to
so
say.
that confused me because I thought that was the pulmonary vein, not the artery that looks wide.
Yeah, so I think I'm coming here. This is very peripheral, and I'm having a hard time finding the pulmonary veins. And then,
What about on the right?
well, I think it's a bit oblique. So, and then I will have a problem finding the artery that lateral. Makes sense? So if this is the vein, then the artery has to go really lateral. So I think the vein is probably somewhere here, and then this is the artery.
Oh.
And to be very honest, there is a time where you push your model. Makes sense? So it doesn't fit perfectly. You push it a bit because everything fits so well. And then probably what it fits very well, and I remember seeing it in cases of Harlem, is this undulating contour. And then that undulating contour, and this is very classic for pulmonary arteries. So then if that doesn't fit perfectly, I push it, I make it fit. Just because all the rest is so clear, yeah.
Okay, thank you.
Probably to clarify this even more, I will try to find, I think, I will try to find a ECG gated CT in a case of enlarged pulmonary arteries, which I think I'm sure I have. And then we can review that anatomy. The anatomy of the heart base, that may be an interesting topic because there was this idea today about lymph nodes, and there are many other things that can go wrong there. And then I think because we have the trachea and the main bronchi, I think we can learn a lot. There are hints, but basically there are many things that can go wrong there, and then usually we have a pretty good idea what's the cause. So that's another interesting topic that I may put 2 or 3 cases together and go through examples of, this is all the situations where this goes abnormal. This is a classic case of this, is a classic case of that. And again, the first look, they all look similar. If you go in detail, they usually hints to go one way or the other. But to learn more about that anatomy, probably comparing this with CT, I'll try to find a CT and then try to have this same view, like a dorsal view, and see, like we did with the PDA, where we reconstructed the anatomy and the actual PDA, where it sits, and compare that with the radiograph. I think going back to the anatomy of the pulmonary arteries in a CT and then coming back to this image is going to help a lot to reconcile this image with the pulmonary arteries, with anatomy.
Yeah, that would be good. My anatomy knowledge of that area is very poor.
Well, it's a very complex area, and it's all about. You will see that it's all about displacements. So it's where things sit, and if one thing gets enlarged, for example, in this case, like one way to really drop the idea of lymph nodes is that the trachea and the principal bronchi are not displaced, and that's a hallmark in if the lymph nodes get enlarged. So it's not the only one, but that's a very important one. So yeah. At the clock face analogy, and then that sits there and it's continuous. Yeah. Okay. Back to work.
Thank you, Mariano.
Thank you very much.
Thank you.
Yeah, thanks very much. Very interesting.
Bye.
Bye.
See you next week.